Thank you. First of all, I would like to thank Sri Lanka College of Pulmonologists and as well as Council for giving us this opportunity to have a pediatric session in this symposium. Next 20 minutes, I would like to talk about management of bronchiectasis and burden and as well as cause of bronchiectasis. Conventionally, bronchiectasis is permanent dilatation and obstruction of the airway wall. It is conventional thinking of bronchiectasis. However, now there are clear evidence for reversibility of this disease, and especially in pediatric age group. Types of bronchiectasis. It is actually, there are several types of bronchiectasis, but it is most important thing is etiological diagnosis or is etiological classification. Broadly, it divided into cystic fibrosis related bronchiectasis and non-cystic fibrosis bronchiectasis. In our part of the world, in Asian population, it is non-cystic fibrosis bronchiectasis more common than cystic fibrosis bronchiectasis. Global burden, actually it is not very well known. However, it is more common in poor or low socioeconomic countries or population, and it is common in indigenous population and as well as low and middle income populations. This article from Indian Journal of Pediatrics, it tried to do an assumption, the prevalence of the bronchiectasis. According to that, according to the calculation, it is about 1 to 2 per 1,000 children under 5 years of age. It's a fairly common disease than we think. Then we go into the management of the bronchiectasis. Actually, it is a teamwork. It lot of individuals that from pulmonologist, pediatrician, and other specialties, as well as physiotherapist, physiologist, nutritionist, and even psychotherapist, everybody involved in management of bronchiectasis. Before going into this, and diagnosis is important. For that, initially it is a clinical suspicion. We have to clinically suspect bronchiectasis according to the clinical findings. Then if clinical suspicion is there, then we have to go for investigation to confirm bronchiectasis. It is mainstay is the imaging. After confirmation of the bronchiectasis, we have to go back to the clinical finding and clinical history and examination. And we have to find out what are the things that is we can evaluate that to find out the cause according to the clinical presentation. After that, we can do investigation according to the finding. Investigation for confirmation of the diagnosis, mainstay is the imaging, that is HRCT chest is the main diagnostic tool. From HRCT, there are several manifestations, several findings, which is compatible with bronchiectasis, from bronchial wall thickening and ring shadows, tram line shadows, signet ring appearance. That those are the different findings are there. They are we have to find out whether they are compatible with bronchiectasis, and after that we can confirm the diagnosis of bronchiectasis. After confirmation, we have to do another investigation first to find out the etiology, that to find out the underlying disease. According to the clinical history and examination, we can do the relevant investigation to find out etiology. Then we have to do investigation to monitor the disease progression, and as well as what are the to see the outcome of the disease. Etiology-wise, cystic fibrosis is the one of the cause, and other than that, non-cystic fibrosis, out of the non-cystic fibrosis bronchiectasis, post-infectious disease is the most common cause for non-cystic fibrosis bronchiectasis. Other than that, there are several other causes for bronchiectasis. This is one of our finding. Our study, according to that, in our country, In Sri Lanka also, we have more cystic more post-infectious bronchiectasis out of non-cystic fibrosis bronchiectasis. There are some other causes they are coming up, and primary serial dyskinesia also may have higher incidence than we think. To diagnose cystic fibrosis, this is very important because we have to see this CF bronchiectasis or non-CF bronchiectasis to see which is the cause. Then we have to first either rule in or rule out CF. For that, we have set chloride test is more established tool. Other than that, there are genetic analysis and as well as physiologic testing. By doing that, we can rule in or rule out cystic fibrosis. Diagnosis of primary serial dyskinesia, actually it is high-tech. Actually, we have higher technologies involved. Therefore, sometimes it is not affordable for countries like us. In European Respiratory Journal, they have published a diagnostic predictive tool to diagnose primary serial dyskinesia. This is principally it is based on clinical findings. According to that, we can easily diagnose primary serial dyskinesia, but to confirm that we have to do other testing. Allergic bronchopulmonary aspergillosis is an important cause for bronchiectasis, especially in agricultural countries and hot and humid countries like us. In tropical countries, it is more common. It is actually could be a cause of bronchiectasis as well as it could be a complication of bronchiectasis as well. Already bronchiectatic children, we can have allergic bronchopulmonary aspergillosis as a complication. Diagnose ABPA or allergic bronchopulmonary aspergillosis, there are different criteria are there, but this group, International Society for Human and Animal and Human Mycology, that group has given a comprehensive diagnostic criteria to diagnose ABPA. Immunodeficiency, again a very important cause because it has extrapulmonary manifestation as well as complications, and there are specific management can be there for different immunodeficiency. Therefore, find out immune deficiency and confirm specific diagnosis very important. Aspiration, again in children, aspiration is very common, and we have to find out aspiration whether it can be again etiology as well as it could be the bronchiectasis can be complicated with aspiration as well. Therefore, finding out aspiration or unsafe swallow is very important in children. After getting a diagnosis, we can go for specific management. Then for the particular etiology, according to the findings and diagnosis, we can reduce the further progression. We can progression of the condition, and there can be some reversibility we can achieve. Pulmonary rehabilitation is the most important part is management of pediatric bronchiectasis. It is airway clearance and nutrition and growth, and as well as other management. It is important in pulmonary rehabilitation. Airway clearance is the cornerstone of management of bronchiectasis, where we have a healthy person, we have healthy mucociliary escalator, which take contaminated mucus from lower airway to upper airway with healthy mucociliary escalator. However, in bronchiectatic children, they have unhealthy mucociliary escalator. Because of that, there is stagnation of contaminated mucus in lower airway, which causes damage. This is a picture to demonstrate coordinated ciliary beating, which helps movement of the mucus. This is again graphical demonstration of coordinated ciliary beating. You can see it is movement. It is very coordinated manner, which helps movement of the mucus to the upper airway. You can see it is very coordinated beating. This is again this is a real pitch. Sorry, this real picture. It is from high-speed video microscope. We can see the again coordinated beating of the cilia, which results in propagation of the contaminated mucus from lower airway to upper airway. The airway clearance, that airway clearance can be hampered by different mechanisms. One thing is abnormal ciliary movement or absent ciliary movement, like in primary ciliary dyskinesia. Then even after infection, we have abnormal or absent ciliary movement. Then there will be damaged mucosa after infection or in post-infectious bronchiectasis or in immune deficiency or other aspiration. We have damaged ciliary mucosa, damaged cilia, then we have abnormal ciliary movements. Then we have thick secretion, like in cystic fibrosis. Again, airway clearance will be disturbed by that. To do a good airway clearance, we have different steps. We have to thin the mucus, which is thin, then we can easily move up the airway. Then we have to mobilize the mucus. Then after that, we have to remove the mucus. To thin the mucus, we have different agents. From that, it is hypertonic saline is well-established agent. It is well-established in cystic fibrosis, and as well as in non-cystic fibrosis. Again, it is now it is used in. Actually, we have done one study. According to that, it is actually randomized control trial. According to that, there is a significant improvement after usage of FEV1 after usage of hypertonic saline in the children with pediatric non-cystic fibrosis bronchiectasis. Mannitol is a well-established agent in cystic fibrosis. In non-cystic fibrosis bronchiectasis, the documents are not, the details and data is not well known. In DNS nebulization, it is an agent to disrupt DNA bonds in neutrophilic rich mucus, which improves liquefied mucus, then we can mobilize easily. NAC nebulization conventionally, it is used in cystic fibrosis bronchiectasis, but according to scientific evidence, now there is no much evidence to support the benefit of NAC nebulization. Therefore, it is not in the usual regime in management. In mobilization of mucus, you know that it is conventional physiotherapy or conventional therapy. There are tapping and percussion or postural genate. It is used in conventional therapy. However, there are other mechanisms. There is breathing techniques. Then we have devices that promote PEEP or peak increase peak end expiratory pressure and also vibration. Their devices are there to use for that, as well as there are external devices like chest wall oscillators to promote chest wall mobilization of the mucus. Then there are devices to improve cough, which used for children with with neuromuscular disabilities to improve their movement of the mucus. And there are other exercises like yoga, yoga exercises also can be used for mobilization of mucus. Then these devices are a bit expensive. Therefore, there are low-cost devices are also there. Then we have done one study to find out this bubble PEP effectiveness of the bubble PEP in our population in non-cystic fibrosis bronchiectasis. There data is still, we could publish the data, but there is significant improvement of the FEV1 in comparison with the pre-treatment FEV1 after this using this bubble PEP. There also we use increased PEEP or increased PEEP and vibration. Controlling of the infection and prevention is important. It is well known that FEV1 deteriorate after acute exacerbation in both cystic fibrosis and non-cystic fibrosis bronchiectasis. And there is data to suggest this reduction of the FEV1 when there is bacterial colonization as well. In eradication of bacterial colonization is well established in cystic fibrosis. There are especially Pseudomonas colonization. What we do the more eradication of the bacterial colonization, but in non-cystic fibrosis bronchiectasis, we have not. There is no enough data to suggest elimination of the bacterial colonization. Then to prevent infection, we have different regime. We have talked about respiratory hygiene more in our this COVID period, as well as we can use vaccination, bacterial prophylaxis, and avoid adverse social circumstances like overcrowding places to avoid respiratory infection. Nutrition, it is one of the important part in management of pediatric patients as well as bronchiectasis both. According to the cystic fibrosis history, there is dramatic improvement of survival of patient with cystic fibrosis after introduction of the pancreatic enzyme replacement therapy. There we can see this red arrow. There is significant improvement, about twofold improvement of the survival after introduction of the pancreatic enzyme replacement therapy in cystic fibrosis. Therefore, nutrition improved and survival improved. Here, the non-cystic fibrosis bronchiectasis also, there is FEV1 is correlated with linear growth. Therefore, the improvement of the growth will improve the FEV1, and it will help to improve non-cystic fibrosis bronchiectasis as well. Complications of bronchiectasis should be managed accordingly. There can be hemothorax, pneumothorax, or even ABP we have already discussed. Those things will be there. In our country also, there are in non-cystic fibrosis bronchiectasis complication will be there. This is some findings of one of our study. It also shows some of the findings according to our study. There are complication will be there. Even pulmonary hypertension, bacterial colonization, or hemoptysis, they are in these complications. Surgical management is also very important. Actually, it is either it is lobectomy or other management of hemoptysis, or even bronchial stenting. Those things are there in surgical management. We have to select patient carefully and do surgical management when it is relevant. We all talk about economy. Actually, bronchiectasis also has economical problem. Then we don't have a good economy, and but we have to in bronchiectasis management, and it is cost. We can see that that horizontal axis is cost, and well-being in the vertical axis. We can see in the lower part is basic management, that basic physiotherapy, counseling, follow-up, and there is basic chest physiotherapy, and as well as inhale medications. Those things are there in lower part. You can see there is significant improvement. We can achieve significant improvement by applying this basic management with lower cost. And we can have high-tech management with higher cost, also have some improvement. But to have good improvement, we have to have very good basic management, and we can have very good improvement. Therefore, it is without having additional cost, also we can manage bronchiectasis children, and we can get good outcome. At last, pediatric bronchiectasis, we need high index of suspicion. We have to get good history and examination and relevant investigation to diagnose bronchiectasis in children. And reversibility is possible if we treat early and promptly. Then it is actually teamwork, and we have to do a shared care in management of pediatric bronchiectasis. And other thing is pediatric bronchiectasis, that more data is extrapolated from CF and CF bronchiectasis and in adult patient. Therefore, we have to have more and more studies on non-cystic fibrosis bronchiectasis in children. It is this is a big tree. It is coming from a small seed like this. Lung is also like that. We have big lung coming from lung bud. But if we get some damage to this plant, we have damage to this seed. Then tree. Then in lung bud also we have to improve nutrition, and we have to good management of bronchiectasis. We have to have good lung like this. Thank you very much.
Thank you very much, Dr. Ganganathan, for excellent presentation. Can we take the question in the last, because we are oversitting? So can we have our next presenter, the management of respiratory infection in childhood by Dr. Chanade Silva.
Good morning to you all. First, I would also like to thank the organizing committee and the council and the scientific committee for allowing a separate symposium for the pediatric pulmonology. So my task is to discuss about the management of respiratory infections in childhood. As you all know, it's a very, very wide topic. So I will just try to highlight some important infections and important areas in the management. All these things are, I'm sure, you're just very known to you. Just a recap of what you know. So, as you all know, respiratory diseases are the commonest clinical diseases in children as well as adults and lead into significant morbidity and mortality. Every hospital visit, respiratory hospital admissions, OPD visits, respiratory diseases take the highest number of admissions according to the available data. So, it's respiratory diseases are the first cause of infection, diseases that lead into significant morbidity. So most importantly, still in a children, respiratory disorders, especially the respiratory infections, are one of the leading cause of death, which can be prevented, especially in the third world countries. So that is very important to have a proper approach to children with respiratory infections management approach to prevent this morbidity as well as, most importantly, the mortality of these small children. So if we consider what are the respiratory disorders, as you know, there are infections as well as non-infective causes. The infections, we just classify into upper respiratory infections and lower respiratory infections under these two headings. There are many types of infections involved in the area according to the pathogens, a wide range of infections as well as lower respiratory. And non-infective causes also, again, a wide range of non-infective causes, including especially some congenital problems to some acquired conditions in children. So, as you know, this upper respiratory and lower respiratory infections, a wide range of diseases are there, including various pathologies, various etiological agents. So it's a wide range. So I just try to discuss few cases with the stress in the management of some important areas of infections. Before that, the important thing to stress is children are not small adults, because there are many important differences between children and adults. So for the management of presentations of respiratory infections also, it's same. There are many differences in the respiratory systems as well as the total body makeup of these two groups. Especially the metabolic changes are there. The immunologically, children are more vulnerable to develop disease, especially the preschool group. Their immune system is maturing, as well as there are important anatomical differences in children as well as adults, the respiratory system, especially the airway anatomy. So because of that, it's very important. Sometimes the clinical presentations, even for the same disease, would be completely different from adults and children. So this is one of the important points to be remember when we are dealing with a child presenting with respiratory symptoms, especially features of infections. So the commonest, as I mentioned, the commonest presentations to the OPD visits or even the hospital admissions, the respiratory disorders. Out of these respiratory disorders, respiratory infections are the commonest manifestations as a disease manifestations in children, I'm sure, as well as adults. So most of the time, the clinical presentation of the respiratory infections in children, some generalized symptoms like fever, malaise, or body aches, and majority of time they have the upper respiratory involvement, cough, sore throat, sneezing, rhinorrhea, and nasal congestions, and sometimes respiratory distress, that is involvement of the lower respiratory tract. Why do they develop respiratory distress, and what does that mean if a child presenting with some sort of respiratory distress? Why do they develop distress? Because when the respiratory system is not in a position to provide the usual functions, to give the oxygen into the body and eliminate the carbon dioxide, those are the basic functions, then body try to increase the minute ventilations. As you know, minute ventilation is respiratory rate into tidal volume. So then body try to generate more negative pressure, increase the respiratory rate to get more air. When this when the body is physiologically trying to overcome the possible hypoxia, developing hypoxia to various diseases, you can see various clinical manifestations or clinical symptoms. Obviously, the first thing is increased respiratory rate through the very good, very effective a reflex pathway. There are chemoreceptors within few seconds increase the respiratory rate when there's a hypoxia, hypercarbia is going on, and when the body is trying to generate more negative intrathoracic pressures to improve or increase the tidal volume. You can see the recessions, the difference between the outer and the inner chest within the chest wall is increasing, so leading to a recession, especially in children, which usually we don't see in adults. Head nodding, tracheal trunk stridor, and grunting like that, and nasal flaring. This is nasal flaring is again to reduce the resistance of the upper airway. All these things features suggestive of child is struggling to get more air into the body. The system is going to fail due to some reason. So if you see these features retrospectively, you have to think, yes, this child is in distress. So any respiratory disease, this can develop, especially with infections. So if you see a child present with fever, cough, sore throat, sneezing, and rhinorrhea, so these are the usual upper respiratory symptoms. Without respiratory distress, the commonest presentation is most of the time is due to just viral upper respiratory infections, or what is called is common cold, involving the nasal cavity, pharynx, plus or minus the sinuses. These common colds, as you all know, it's majority of time are due to viruses. There are various types of viruses causing this infection, especially the rhinovirus group is a major culprit, as well as very occasionally the bacterial pathologies are there. But over 90% of the time, the etiological agents are viruses. Sometimes even more than one virus would be there are possible co-infections leading to respiratory, especially this common cold. So other thing is, sometimes these days also last few months, few weeks, we have experiencing more symptoms, especially due to this flu, due to influenza infections. Those symptoms are almost same, but the flu or the influenza in children, rather than common cold, the symptoms are little worse, more generalized symptoms, more ill, and the symptoms durations is little more. But it's very, very difficult to differentiate clinically. So how do we manage these children with upper respiratory or the common cold? Basically it's a self-limiting disease. So because of that, it's basically supportive treatment, and we don't need any hi-fi treatments. It's so common these days. Every mother, every parents complain of my child is having cough and cold every time when they attend to school or classes or daycare facilities, sometimes once a month, sometimes twice a month, like, yes, because of it's very, very common. There are many over 200 different types of respiratory viruses are going on. So most of the time, the management is supportive, and as it's mainly viruses, so no need to give antibiotics. So that's one of the important key message. So uncomplicated upper respiratory tract infections, common cold, please do not use antibiotics unless there are clear evidence of bacterial involvement. Another thing is use of steroids. So that is also, we are seen very frequently, but for upper respiratory infections, uncomplicated common cold, should not use, and sometimes the symptoms relieve, especially the first contact level steroids are being used, but again, that also reduce the inflammatory response or the protective response to tackle with these viruses. So please do not use steroids unnecessarily in patients with obvious common cold. So most of the time the management is symptomatic with analgesics, antihistamines, and sometimes children we can use nasal decongestion, but again that's a little controversial. Sometimes it might produce little symptomatic relief. And most of the time, reassurance would be. These days, the problem is that the parents are very, very anxious because children are developing these infections very, very, very frequently. But reassurance is very important because this is the time they are exposed to these common viruses and acquiring the immunity. So when they acquire the immunity to gradually to these very common viruses, so after about 5 to 6 years of age, this frequency of infections will reduce. So that message should be given to the parents very, very correctly. So other important thing is the persistence of symptoms. Sometimes these symptoms will persist for longer durations, especially this cough. Cough is a distressing problem. It's very, very natural to have this cough persistent for few weeks, even 3 to 4 weeks. That's again sometimes might not work for various regimes, including cough suppressors. And we usually do not recommend cough syrups to children. Against the natural history, reassurance is the most important thing in these uncompleted viral upper respiratory tract infections. So next scenario, again with these upper respiratory symptoms, now this child is having hoarseness of voice, barking, cough, and inspiratory stridor. Yes. So this again common present is small age, especially around 2 years of age. This is viral croup or the acute laryngotracheobronchitis. It's involving the inflammatory edema of the larynx, trachea, and bronchitis, causing airway narrowing, leading to these symptoms. And it's again most of the time due to viruses. Para-impressible virus is the commonest culprit. There are different score systems to assess the severity of this disease, because it can be very mild disease to severe disease depending on the degree of airway compromise in these children. So management, again, most of the time supportive, but as this is inflammatory edema, the steroids has a place. Here, definitely, yes, steroids has a place. The dexamethasone is the usual steroids we are using. Sometimes the single dose would be enough. In uncompleted cases, 0.15 milligram per kilogram single dose, but sometimes severe cases, we might have to go for repeated doses. And nebulization with adrenaline also has a place here, because again, adrenaline do the vasoconstrictions and that reduce the inflammatory edema, relieve the symptoms. Another child, again, usually they are present with upper respiratory symptoms, cough, cold, sneezing, rhinorrhea, and now the child has lower respiratory symptoms, crackles, diffuse crackles with variable degree of respiratory distress. Yes, especially small children, infants less than 1 year of age, most of the time these are due to bronchiolitis. So bronchiolitis, it's again inflammation, the infections due to viruses, mainly the respiratory syncytial viruses, leading to involvement of the lower air with the small air with the bronchioles, and it can lead into this inflammatory changes, leading to partial obstructions, leading to overinflation or complete obstructions of these small areas, leading to patchy areas of atelectasis. So both can be there. So again, bronchiolitis is a clinical diagnosis. Sometimes you can do X-ray, you can see patchy areas of consolidations or areas of atelectasis with hyperinflations due to air trapping. So again, management of bronchiolitis is supportive. Even this is a very, very common disease. Again, the management is supportive because whatever the measures we use, steroids, bronchodilators, these things, nothing works because the changes are different. There's no bronchospasms in most of the time because it's involved in the small air with the bronchioles, which doesn't have a significant muscular wall. So again, supportive therapy with providing oxygen depending on the degree of hypoxia, as well as providing hydration, and sometimes might need further respiratory support like high flow nasal cannula therapy. So high flow nasal cannula therapy usually recently revolutionized the management of these children with bronchiectasis in ward setups and reduce the admissions to ICU. So it's again bronchiolitis, correct diagnosis, identification, and especially identification of the children with severe disease and early introduction of respiratory support, including high flow, would be the key in the management of these children with bronchiolitis. Again, another child present with same upper respiratory symptoms with change into lower respiratory involvement with physical examination findings of crackles, especially localized crackles with variable degree of respiratory distress. So this is localized, so yes, most probably due to pneumonia. As you know, pneumonia, the lower respiratory involvement of the lung infections, infection of the lung parenchyma, is also in the most of the time due to viruses. And some cases, especially Western countries, they have identified up to about more than up to about 70% of the time, even for pneumonia, the cause is the culprit or the etiological agent is the viruses. Many different types of viruses like respiratory syncytial virus. There are a lot of viruses causing the pneumonia also in children. There are many bacteria, so the bacterial pneumonia is one of the important things. That is one of the important killer in children, especially preschool children, leading to significant mortality, especially the Streptococcus pneumonia, Haemophilus influenzae, and group A Streptococci and Staphylococcus aureus. These are the very important bacterial pathogens leading to pneumonia. Apart from that, the Mycoplasma pneumonia is one of the important culprit, as well as don't forget about tuberculosis at any time, any age, any child presenting with respiratory symptoms. Another important thing is sometimes there would be bacterial and viral mixed infections. Up to about 30% of time, these mixed infections also possible in children with pneumonia. So most of the time, dealing with children with community-acquired pneumonia, acquired infections within the community, they present with respiratory symptoms, as I mentioned, including the upper respiratory as well as the lower respiratory tract infection symptoms, as well as, this is one important thing, sometimes they can have even non-respiratory symptoms like abdominal pain, due to this local irritation or referred pain, sometimes they can have, or even sometimes there might be erroneously diagnosed as even meningitis, appendicitis, or acute abdomen in children, but the problem actually is pneumonia. So how do we diagnose? Again, clinical diagnosis, WHO has very simplified the definition of the pneumonia as fast breathing and lower chest syndrome, but our setup, as we have more facilities, proper history examination and investigations are important. The primary mode of diagnosis is the imaging modalities. Chest X-ray, with the chest X-ray we can localize or exactly identify the lesions. So X-ray patterns, today morning there was a very good lecture about the interpretations. I'll just go through few slides to identify it. So upper lobe pneumonia, you can see the collapse of upper lobe, so just pneumonia, consolidations plus collapse consolidations. And middle lobe involvement, the loss of right heart border, that's called silhouette sign. That's clearly identify the middle lobe involvement. Here the heart border is intact, but there is opacity, so that means that's not touching the heart border. That means it's not in the middle lobe. So that's the lower lobe, and you cannot see the diaphragmatic border. So it's same, left lower lobe right lower lobe pneumonia, and left side, left upper lobe involvement. The left other one is you cannot see the heart border, so that means it's a whole upper lobe and lower lobe, the lingular lobe is affected. And with the intact heart border, that means only the upper part of the left upper lobe is affected, right? So, and then you cannot see you cannot see the left heart border, that means it's the lingular lobe involvement like that. So this is the lower lobe involvement. And this is another specific entity, usually we don't see in adults, small children, the round pneumonia. Again, it's very specific thing, various lobes can be affected. So the management, again, supportive therapy as well as appropriate use of antibiotics in these children, how to maintain the oxygenations, hydrations, electrolytes, monitoring, and appropriate antibiotic depending on the child's clinical condition. Finally, I just want to go through this also. This is not a direct infection, but protracted bacterial bronchitis, the emerging conditions, and we are seeing many patients in our setup also, children presenting with persistent chronic or prolonged wet cough without other significant evidence of respiratory tract infections or the pneumonia. So this is again related to infections, type of isolated wet cough without signs of another cause, and this has been described in 2006 by this lady, Professor Anby Chang, but it is there. So protracted bacterial bronchitis, the main features are chronic wet cough with usual no other symptoms. Child is clinically well and even X-ray is normal. Microbiologically, sometimes we may be able to identify the commonest culprit is Haemophilus influenzae, sometimes strep pneumonia or some other bacteria would be possible. Persistent low-grade infections involving the lower airway or the bronchi. So this is the diagnostic criteria. Presence of this wet cough, absence of other symptoms suggestive of other disease, and cough usually resolves with after about treatment with 2 to 4 weeks of course of appropriate antibiotics. So the management's mainly Comesiclave is a main amount of treatment, but we have to give prolonged durations, a minimum of 2 weeks, 2 to 6 weeks, sometimes a little more. And other thing is still there are some controversies going on. Still this is a disease under studies, whether this is a precursor for this bronchiectasis we just discussed. It's an initial manifestation of bronchiectasis. So the progression of bronchiectasis, the PBB to bronchiectasis. And we have to, other most important thing is about respiratory infections. To prevention, we have noticed this during COVID time. So I'm not going into details about the prevention. You know how to prevent respiratory infections. We have to prevent acquiring these infections to avoid most of the time to the respiratory route. We have actual practice these things during COVID time, but now we are forgetting about these measures. But so it is very important, especially to prevent these infections going in children and among schools. So in summary, commonest presentations in OPD towards respiratory infections. So there's a wide spectrum of manifestations. So most important thing is very clear identification, rational management. Don't use antibiotics unnecessary for uncomplicated viral infections, and thorough assessment and early interventions, high degree of suspicion is important to prevent the unfortunate causes of death due to respiratory infections. Thank you.
Thank you, Dr. Chandra, for that wonderful lecture. We have to advance next lecture because we are having an online lecture from the by Professor Gary Connect at now. He's talking about management of pediatric asthma. What is new?
Thank you very much. My name is Professor Connett, and I'm going to be speaking to you today about what is new in pediatric asthma. And I thought what I'd do is not so much come up to date with the very latest research, but perhaps reflect on what we already know about asthma, and maybe have a new perspective on how we go about treating it during childhood. And I thought I'd start with this quote, which is, "There is nothing new in the world except the history that you do not know." And I suspect you will know some of the things that I'm about to tell you, but what I want to try and think about is how that has impact on how we treat children today with asthma in our clinical practice. And it's quite relevant to be talking about this because, as you might well be aware, the prevalence of asthma is increasing in those countries which has less of the disease, whereas it's stabilizing in those countries where it's already got a very high prevalence. And the reasons for this are quite complex. The disease appears to be increasing, particularly in developing countries. And it's thought that in some way, maybe it's the Western or more developed lifestyle, or maybe the ethics and the way in which societies are organized might be important in determining the changes in the prevalence and the severity of asthma across the world. That's another topic for another discussion. So I thought I'd start off by thinking about what is asthma and just challenge somewhat some of the common concepts that we have about disease. And the first one is that asthma is an inflammatory disease. Now, nobody is going to not give inhaled corticosteroids for a child with chronic asthma. Clearly, these drugs are highly beneficial, but the extent to which inflammation is the entire story, I think, needs to be challenged. And we know, for example, that FeNO, exhaled nitric oxide, a marker of eosinophilic inflammation, an important part of the disease process in asthma, can be useful in supporting a diagnosis. A high FeNO level suggests the presence of asthma, But in pediatric practice, it doesn't always give us the answer that we want. And only in a half of cases is FeNO raised when we have other evidence for the disease. We know that high levels of FeNO can also occur with other allergic problems like rhinitis, eczema, and atopy, without necessarily having the presence of asthma in the airways. And we know that things like inhaled steroids and tobacco exposure can actually reduce the FeNO levels. So it's not quite so straightforward as we might think. And we know when it comes to disease management, whilst many clinical trials have tried to use FeNO, a marker of inflammation, to guide the use of inhaled steroids to better control the disease, the results have been negative. And so hence this statement here, which still holds true today, that the BTS, the Sinai UK guidelines for asthma, do not recommend using regular FeNO measurements to manage asthma inflammation. The trials that have been done to try and do that, unfortunately, do not work. And we know that giving high doses of inhaled steroids, something that's commonly done for patients who are not well controlled on low dose steroids, do not work according to the evidence base. This is the Cochrane Review, an international organization that does meta-analyses of randomized controlled trial data to look for the best evidence to guide treatments for all diseases. When it comes to asthma, what we know from the randomized control trial evidence is that high doses of inhaled steroids, and that holds true for beclomethasone, fluticasone, and budesonide, do not lead to clear improvements in symptoms over low doses. There are 81 randomized controlled trials in this area. 80 are negative for clinically important asthma outcomes, such as acute asthma attacks, the causes of more severe asthma, and the potential for mortality or near fatal asthma. What we do know, however, is that higher versus lower doses of inhaled steroids have an association with more side effects over efficacy. Something that is really largely ignored when it comes to clinical practice. And so this little cartoon here suggesting that maybe what we think need to be doing is not more of the same and expecting a different result. We need to think differently rather than just giving more drugs. This is not new evidence. Here's a study going back to as early as 2004, looking at fluticasone, showing that the dose response between just 100 and 200 micrograms of that drug in pediatrics plateaus very early on for important clinical outcome measures like lung function, the use of bronchodilators, and nighttime symptoms. Similarly, with leukotriene receptor antagonists, a commonly used add-on treatment for patients who are poorly controlled despite low-dose inhaled corticosteroids, the evidence base is not there to support that practice. And indeed, there are clinical trials suggesting that the outcomes when it comes to symptoms, as reported by patients, depend upon what is told to the patient about the effectiveness of the drug. We have 5 groups of patients on this slide. The MNT refers to the Montelukast, the PLA is placebo, ENH means enhanced information about the drug, and NEUT, NEU2, no information about expectations of benefit. When a placebo is given with high expectations of clinical effectiveness, the response in that group there in the middle of the graph is as good as Montelukast given with or without information about the drug's benefits. So the suggestion being that the placebo effect is very important in determining the extent to which this kind of medication is effective in treating patients. Now, what about asthma as an allergic disease? Well, we know there's an association between atopy and asthma in population studies, but that relationship is not straightforward. And these are studies which have been done in populations where the occurrence of asthma and the occurrence of atopy has been looked at over time in the same population. And the gap is around 10 years. And you can see here in those first 3 studies, looking at chunky numbers of patients, that when the patients have been looked at in those populations 10 years apart, the percentage with asthma has increased considerably in all of those populations, but the occurrence of atopy as measured by skin prick testing has stayed the same. So the relationship is not necessarily causal. And here we've got another population where the occurrence of atopy has increased. This is when the Berlin Wall came down, uniting East and West Germany. Atopy increased in East Germany considerably during that time, but the occurrence of asthma stayed the same. So the relationship is not that straightforward. And that's perhaps not surprising because we know, for example, from the research looking at allergen avoidance, house dust mite in particular, the occurrence of asthma symptoms is not improved by those measures. Those clinical trials have all been negative, and the BTSR national guidelines in the UK say that such measures are not recommended. And similarly, the research looking at animals and animal allergens, cats and dogs in family homes, the evidence is that removing pets from homes where we have poorly controlled asthma is often paradoxical with no benefits to the patient. So these things are not necessarily causal in the way that you might expect, albeit there's an association between such symptoms and the occurrence of the disease in patients during childhood. Maybe there's some other common underlying factor that's there to explain the association. Finally, I want to think about asthma as a genetic disorder, and I'm quite interested in genetics of asthma and the twin studies that have been done to look at this, having twins of my own. And twin studies have been a very useful way of trying to determine the extent to which nature versus nurture determines the occurrence of a disease. Monozygotic twins share the same 100% genotype. And so if you compare the occurrence of a disease in monozygotic twins versus, for example, my dizygotic twins, where they only share half the genes, you can then calculate the extent to which heritability, genetic determinants are important in causing the disease in a population over time. So that's what twin studies do. And what they tell us is that genetic factors are important. They suggest that approximately 60 to 80% of asthma susceptibility is due to genetic causes, with little evidence that environmental factors can be picked up when looked at in this way. And as you might be aware, there's been an explosion in asthma research looking for that genetic factor. We can now do what's called genome-wide association studies. Here's the PubMed exponential rise in the number of asthma genetic studies that have been done, trying to find those important genetic determinants of the disease. This is looking at what we call SNPs, single nucleotide polymorphisms, which might be importantly associated statistically with the disease occurring. There have been many of these studies. This, I think, is one of the ones which has shown the highest heritability for asthma, a genome-wide association study carried out on the UK Biobank. And we've got here the population of people with asthma only, hay fever and eczema, and those with both conditions. And you can see here a large number of SNPs, candidate genes, which are occurring statistically more common within those 3 groups of patients. But the genetic heritability only comes to around 20%. That's the best study. Most studies are single figures. And so the point being that we're not getting anything like the high percentage as suggested by the twin studies. There's a gap there. There's something that's not being explained. And the common explanation that's now being looked at is the epigenome. the extent to which the environment might determine the expression of SNPs of single genes due to environmental factors interacting with the genotype in a way that might be important. But again, those studies looking at epigenetics are not providing the full picture. We've had a very large study done on the Isle of Wight, an island to the south of us here in Southampton. And researchers there have tried to look at both the genome-wide association genotype and also methylation, an epigenetic way in which genes are expressed, to try to see if we could predict childhood asthma subsequently as a result of having this information. And essentially, the answer is no. The predictive performance of looking at genetics, looking at these outcomes epigenetically, genetically is negative for the broad phenotype of asthma as we currently understand it in childhood. The implication there being perhaps is that maybe asthma is a very diverse disease due to very different genetic pathways which result in a similar outcome of wheeze in childhood in a very complex way. But perhaps what I want to suggest is there's something more simpler going on, because the twin studies may be explained in a different way. So heritability, the genetic inheritance of a disease, is that which is traditionally attributed to a genetic variance that we have been looking for in those genome-wide association studies. But perhaps it could be due to another mechanism. And here's where I want to try to push the envelope slightly and think about the possibility of mimicry. Now, mimicry, you can see these people rubbing their noses, is the unconscious or autonomic imitation of gestures and behaviors performed by others. And that can extend to the occurrence of reflexes, things like sneezing or coughing. I give an undergraduate lecture on cough. And by the end of the cough lecture, in which there's a lot of cough videos, half the audience are coughing in a reflex autonomic repetition of those behaviors. So when we look at the twin studies, what we see is that the increased genetic susceptibility of asthma over time that we see in twin studies which have been repeated is very much due to the increased concordance of the disease in the identical twins. So it's the identical twins that are suggesting the higher increase in the genetic susceptibility. And identical twins, we know from psychology research, are far more empathic to each other than non-identical twins. That makes sense if you think about it. They look the same, and therefore they are more empathic to how the other is behaving than non-identical twins who may not even be the same sex. So an identical twin is more likely to have autonomic behavior that copies their twin than a non-identical twin. And that may extend to the occurrence of respiratory symptoms. We know it can happen for cough, for example, but perhaps it can also occur for bronchoconstriction and the phenotype that suggests the presence of asthma. And this raises the issue that asthma is very much an autonomic disease. And we do have evidence for this. We know that the bronchial smooth muscle that becomes importantly constricted as a cause of symptoms is innervated by the vagus nerve, by the parasympathetic nervous system. We know that severe asthmatics have increased parasympathetic responsiveness than less severe patients. Asthma patients tend not to have the sympathetic fight or flight response, but instead have reflex parasympathetic pathways which cause bronchoconstriction. The sympathetic nervous system does not innervate the airways. It's all parasympathetic. And this probably explains also why we see more severe asthma in those patients who have stress. My most severe patients are certainly all severe for that reason in the majority of cases. So what might be the underlying reasons why this is occurring? Well, I haven't got time to go through this in detail, but one of the most important predictors of wheeze in childhood that's poorly appreciated is that maternal stress is an important predictor of wheeze in childhood. And the odds ratio there of 1.56 is higher, for example, than antenatal maternal smoking and most other important risk factors for the occurrence of wheeze in childhood as listed in this table. And many of those other factors which have been described are probably all confounded for by maternal stress. And maybe it's that maternal stress that's working antenatally that's affecting the development of the parasympathetic nervous system. And again, I haven't got time to go through this in detail, but I would refer you to my recent publication in the Archives of Diseases in Childhood that explains in more detail a possible mechanism whereby maternal stress might be affecting the development of the parasympathetic responsiveness and leading to the expression of asthma as possibly reflex bronchoconstriction through an exaggerated triggering of the diving reflex, which is a mechanism whereby smooth muscle in the airways can be contracted. I want to finish with a couple of slides which I think are important. This is one of my favorite slides, and it's taken from the licensing use of fluticasone. And what you can see there is the placebo effect of the drug trial. The patients in diamonds are receiving fresh air in their inhaler, but their lung function is improving to around 60% of the pharmacological effect of the inhaled fluticasone. Asthma patients have enormous placebo effects that determine their outcome. So it's around 60%. If a patient has symptoms, we automatically think it's due to a loss of the pharmacological benefits of what we're doing. And the temptation is to give more drugs. But what could be happening is that the patient is less well because they have lost the placebo benefits of treatment. So this, I think, has really important implications for treatment. We need to be engaging with our patients to get them to maximize the extent to which they benefit from the medication we're giving them through those autonomic placebo parasympathetic pathways. And we do this by getting patients to believe in what they're doing to treat their patients, and we provide ongoing supportive care, a narrative of high expectations and good response to treatment to keep patients well. And I think it's that simple. Patients do well if they are well looked after and they believe in what we are doing to help them, to treat them, to make them better. Very briefly, just want to show you a couple of slides of what we do to treat asthma pharmacologically in Hampshire, in my part of the country. And in the 12 plus, it's one drug. We use Symbicort. We're avoiding the use of salbutamol as far as possible. We do a lot of what's called MART treatment, as required use of the devices for symptoms as needed. And in the younger age group, we use low-dose inhaled steroids. And we're trying to avoid, certainly in primary care, the use of higher doses of medication. So I'll stop there and I'll happily take any questions. Thank you very much for listening.
Thank you, Professor Gary Connect, for that informative lecture on management of pediatric asthma. If the audience have a question for him, now can proceed because he's awaiting online.
Yeah, thank you, Gary, for your very interesting and elaborative presentations and new thoughts about asthma. We learn a lot. One question about this MART therapy, because that's also been popularized in children as well, because now initially it's mainly recommended for adults. What do you recommend to use? What specific age groups you recommend for MART, and what's the place for it in preschool children?
Oh, good question. Thank you very much for that. Yes, well, it's licensed in the UK down to the age of 12. we tend to use the Symbicort Turbohaler in most cases. We tend to use the low dose, the 106, and in secondary care, we also do similar down to 6 years of age, down to the 6 to 11-year-olds. It's licensed, I think, in that way in some parts of the world, not yet licensed in the UK, but we're on the verge of trying to introduce that into primary care in our own locality. In the preschool age group, that's quite a step. That's significantly off license for our practice in the UK, but we're about to produce some new guidelines for treating wheeze in that age group. And one of the things that we're going to be exploring is the intermittent use of inhaled steroids for recurrent acute viral associated wheezing in this age group. So yeah, I think we're on a journey with this, but certainly the effectiveness of MART, I think is very good, and I'm an absolute convert to it. And I would say that 90% of my patients now in secondary care, and that includes the most difficult asthmatics in our region, are being treated quite effectively in the majority of cases with that approach. So thank you for the question.
Any further question? Thank you very much, Professor Gary, for your time and for an excellent lecture. Thank you very much. Shall we proceed for our next topic? That is a current knowledge in diagnosis and management of congenital ILD by Dr. Aruna. In Pediatrics, Respiratory and Sleep Medicine, and Srimimavo Bandarnaike Specialized Children's Hospital in Sri Lanka.
Good afternoon for the introduction, and good afternoon, everybody. And after 3 very interesting lectures, at last I'm going to talk about something very grey and hazy and a bit of lazy also, because it is ILD in children. Okay, because what I say is ILD is not it's a wide and heterogeneous group of innate or genetic or infection or inflammatory disease. This is very diverse but less common in children than in adults. And prevalence is also very low, that is less than 1 for 100,000 individuals. And because of this low prevalence, a single center usually see only few cases a year, 1 or 2 cases per year. And because of that, because of this low prevalence, the experience regarding the diagnosis and treatment is also very limited, and less than a handful of randomized control trials are available regarding the treatment of the childhood interstitial lung disease. On that background, European protocol for the diagnosis and initial management of interstitial lung disease was created in order to harmonize the diagnostic approach across the Europe, that is to get peer reviews. That is actually very rarely happening in Sri Lanka, to take a peer review for some sort of a illness that you cannot take decisions alone. So this was created to get a peer reviews and make a register, as well as to take samples for more samples for the randomized control trials. So if I show you the picture, interstitium is a small space between the alveolar epithelium and the between alveolar epithelium and the capillary endothelium. It's a very small limited space, and most of the diseases we are discussing today is not limited to this space. It involves rest of the lung parenchyma, sometimes vasculature, as well as the airway and alveoli also. So most centers like to define it as diffuse lung diseases than interstitial lung diseases. And what is then child syndrome or childhood interstitial lung disease syndrome? So diffuse lung disease is a bit of a large spectrum. It has a commonly recognized entities like pulmonary infection, immunodeficiency, cystic fibrosis, ciliary dyskinesia, aspiration, and lung disease associated with congenital heart disease. When we exclude these means they are very common or commonly occurring diseases, small portion of the children remains undiagnosed. So the child syndrome is referred to that sort of a undiagnosed part of the diffuse lung diseases. So if we define the child syndrome, it defines as presence of at least 3 of the following 4 criteria without knowing the underlying lung disease, without known underlying lung disease. They should have respiratory symptoms like cough, rapid breathing, difficulty in breathing, or exercise intolerance, or respiratory signs as we know, tachypnea, recession, so clubbing or failure to thrive, or added breath sounds or respiratory failure with hypoxemia and diffuse abnormality in the chest X-ray or HRCT. Okay. Child EU network, European Union network, has classified the childhood interstitial lung disease based on the clinical, radiological, genetic and histological findings, and it broadly categorized these childhood lung diseases into 2 main groups. One is ILD more prevalent in infancy, then second group is ILD not specific to infancy or childhood. So here I'm not going to go into more details because this limited time is not enough to discuss with you regarding each and every ILDs, but what I have to show here is how diverse is that. So ILD more prevalent in infancy still can be divided into basically into the 4 groups, that is diffuse abnormality, diffuse development disorders or growth abnormalities, and specific entities with underlying etiology, and surfactant dysfunction. Out of these 4, the first group usually have very premature histology. Let me see, if you take the histology, it contains only the respiratory part of the airways. It does not have conductive part of the airways. It does not have the respiratory parts of any airways in the histology. So that is not compatible with life. These kids usually become symptomatic just after birth, and they usually die within few hours or few days. And the second group usually have the histology that similar to the premature infants. And third and fourth groups are a bit different, and it also have a lot of other subcategories. In the third group, there are 2 entities called pulmonary interstitial glycogenosis or PIG and neuroendocrine hyperplasia of infancy, which was not described in adult lung disease. And the rest is, the second part is ILD not specific to infancy and childhood, and it also can subdivide into 4 or 5 groups, and that is, first one is ILD related to the systemic disease processes. As we all know, it contains some diseases like ILD occurring in the Langerhans cell histiocytosis. And the second group is ILD that occurs in the normal host due to the exposure, like hypersensitive pneumonitis and aspiration pneumonia. And third one is ILD in the immunocompromised host. This usually happens due to the recurrent infections as well as the prolonged infections or unusual infections. And the third one is, fourth one is ILD with structural vascular changes that includes the pulmonary hypertension, vasculitis, and other sort of vascular diseases. And the last one is ILD related to the restrictive lymphoid diseases. And what are the clinical presentations? Usually the initial, that means ILD which confined to the infancy or more common in infancy, usually present just after birth. They can present mainly in 2 ways. The first way is unexplained respiratory distress in a term baby. We usually does not expect respiratory distress in a term baby. If it happens, it can be ILD. Usually they frequently develop into the respiratory failure. And the second is ILD occurs in can also occurs as a in a marginal preterm or preterm babies, which are the respiratory distress is disproportionate to their clinical picture. If the child born after 34 weeks, we do not expect that sort of a respiratory distress in this child, but it also can present like this. And most of the conditions end up in death if they present immediately after birth or survive with lung transplantation. And some makes a partial recovery and they survive in chronic respiratory failure. And then they can present bit later, birth to 2 years. This is mostly non-specific. It usually have common respiratory symptoms like other respiratory infections, bronchial asthma and that all. And they can present with rapid breathing, failure to thrive, dry cough and wheezing. And usually we can detect the hypoxemia and rest of other respiratory signs like tachypnea, recessions and crackles. And it can also be associated with pulmonary hypertension and gastroesophageal reflux. Some children can present even after that. The presentation usually the same, but in older children sometimes we can detect ILDs because as an exercise-induced breathlessness. When we evaluating ILD, first we should evaluate for the hypoxemia because that is most of the time it is the first abnormality which raises the concern. So when we evaluating the child for the hypoxia, we should evaluate whether the child is becoming desaturation at rest or during activity. If they are becoming desaturation at rest, we should evaluate that during awake and during sleep. And if desaturation not occurs rest, in older children, we should do appropriate exercise test to unmask the desaturation. And after that, we should do the cardiological evaluation, echocardiography. Usually, when a child comes to us in our usual ward setup, we request echocardiograph at last or a bit later. But in this case, we should do early echo than the later, because we can evaluate for the presence or absence of pulmonary hypertension and the severity of the pulmonary hypertension. And also, we should exclude the cardiac mimics, because sometimes, roughly about 7% of the time, when we are suspecting ILD, they end up in a structural heart disease. And based on these two, we can stage the severity. That means with the symptoms, hypoxemia and the pulmonary hypertension. The grade 1 does not have, they are asymptomatic and incidental diagnosis, and the score 5 means they have hypoxemia at rest as well as the pulmonary hypertension. So then we can do the lung function. The lung function cannot give much details about the diagnosis, but usually the spirometry is restrictive, and in special situations like knee-high neuroendocrine cell hyperplasia, it can be obstructive, and diffusion capacity usually reduced. And chest radiography is mostly non-specific and sometimes can be normal, but it will help to exclude the ILD mimics, that means especially the infections. And also it will show the extent and the pattern of the involvement. And HRCT is the most important investigation we can do as in a basic setting. And it usually accurately identifies the ILDs, and also based on that we can do the planning of the rest of the investigations. Usually when you are doing a HRCT, it should be done in a specialized center in order to minimize the radiation and obtain the maximum information. And when we are doing HRCT, this is very important because most of the time HRCT is done while the child is awake. And when we go to the interpretation, it is very difficult to interpret because of the motion artifacts, breathing artifacts and that all. So if the child is less than 5 years, definitely they should undergo general anesthesia or sedation with controlled ventilation. And even if they are more than 6 years, if you want to do awake without anesthesia, they should be able to hold the breath reliably. Yeah, and also most of the time we do not need to give a contrast, because if we give a contrast, we cannot interpret lung parenchymal changes, especially ground glass changes. So depending on the HRCT findings, sometimes we can identify the ILD reliably and we can classify it. But sometimes we can identify, but we cannot classify it. Sometimes we can't identify the ILD, and we can say it is unlikely. If the ILD is unlikely, we should do the diagnostic workout to identify the non-child pathologies. And if we can identify it and we can classify, then we should start treatment and the follow-up. If the ILD is possible but we cannot classify, then we should go for the ILD diagnostic algorithm. These are three rare conditions we can completely identify the ILD with HRCT. One is pulmonary alveolar proteinosis, and then second one is knee high, and then the hypersensitivity pneumonitis. And if we can't identify the ILD, and we can identify, but if we can't classify, then we should go for the rest of the investigation that include genetic investigations, including the genetic investigations. If we can identify with genetics, then we can start treatment. But if we can't identify, then we should go for the bronchoscopy. And then also we can go for the, if we can't identify with the bronchoscopy, then we should go for the lung biopsy. Actually the specific genetic alterations has reported in up to 20% of the children with ILD, and definitely in the future the number will increase and it will change the diagnostic algorithm also. When we talk about the bronchoalveolar lavage, the limitation is bronchoalveolar lavage represent usually the distal bronchioles and the alveoli, not the pulmonary interstitium. But still it will give some help by excluding the coexisting infections, and sometimes it will give very important clues regarding the underlying ILD. We can identify the pulmonary alveolar hemorrhage and pulmonary alveolar proteinosis and sarcoidosis, Langerhans cell histiocytosis, can have idea about the aspiration, hypersensitivity pneumonitis, and sometimes certain surfactant protein deficiencies using bronchoalveolar lavage. So the lung biopsy is the final or last or gold standard of diagnosing ILD, and sometimes it is the last step, but sometimes when the disease is very progressive, especially in the infancy, we have to do early lung biopsy. So when we go for the lung biopsy, transbronchial biopsy does not have a place in the pediatric practice. What we do is video-assisted thoracoscopic surgery because it has very limited side effects comparing to the open lung biopsy. And when we take lung biopsy, we should at least take from the two sites with different severities. And we should send samples for the microbiology and if possible for immunofluorescence and genetic studies and electron microscopy as well as the conventional microscopy. Some mandatory staining will be done by the histopathologist as well as the specific stainings as we requested for the specific diseases like CD34 for the vascular markers or bombacin stain for knee high, and CS100 and CD1A for the Langerhans cell histiocytosis. So in brief, regarding the treatment of the ILD, up to date there are no special treatment approved for the childhood interstitial lung disease. What we do is empirical treatment because disease is very rare, so we do not have much evidence, and we have only small number of randomized control trials. And most of the treatment is depends on the case series only. Mostly we treat with the anti-inflammatory drugs and the immunosuppressive drugs. So most common treatments are corticosteroids and hydroxychloroquine and the azithromycin. So recent randomized control trials show good safety but not much benefit of the hydroxychloroquine as we expected before. And less frequently used drugs are the azithromycin, cyclophosphamide, and the colchicine. And usually acute exacerbations are treating with systemic steroids reduce the ILD, reduce the inflammation, as well as antibiotics and inhaled bronchodilators. And critical patients with which needs ventilation and means rapidly progressive disease, we have to use pulse methylprednisolone. For the long-term treatments, we should avoid steroids as much as possible because of the frequent and severe side effects. The whole lung lavage also have a place in some ILDs like pulmonary alveolar proteinosis, but it is very difficult and time-consuming treatment modality, which usually done in specialized centers. When it comes to a pediatric practice, we need a special techniques because pediatric means small children have very small airway. And a lot of other drugs, as mentioned here, has means tested successfully for the various type of ILDs with various genetic mutations, and some of them have reduced the need of whole lung lavage. The antifibrotic drugs have place in the adult ILDs. Some have tried in the pediatric ILDs in a patients who are 6 years to 17 years, but does not show any sort of a significant, statistically significant benefits, but with a similar pharmacokinetics and safety profile similar to the adult patients. So lung transplantation also have a place in ILD, especially those who are having a different mutations of the surfactant protein deficiencies. And few single lobe lung transplantation from live donors has been reported in patients with ABCA3 deficiency, that is also surfactant protein deficiency. And not only this specific management, supportive management we can do very easily. It is very important. It includes supplementary oxygen when the patient is having poor gas exchange, and invasive or non-invasive ventilation when the child is having a respiratory distress, and nutrition rehabilitation and the growth monitoring for the patients with poor somatic growth. And rest of the supportive management, including aggressive treatment for the infective exacerbations, vaccination, and avoidance of harmful environmental exposure, and good personal hygiene and prevention of the gastroesophageal reflux. So at the end of the treatment, we can measure the response. So improvement or deterioration will be measured by the physiological outcomes of the outcomes, mainly the heart rate, respiratory rate, and saturation. And if they lost the need of oxygen, need of oxygen and need of mechanical ventilation, that is the best response for the treatment. Thank you very much.
Thank you very much. We can have one question each if anybody is this. Anybody has any question? If not, then I like to congratulate all speakers for a different past pediatric topic to be presented very simply and a very enthusiastic way. Thank you very much.
Thank you, speakers, for that insightful series of presentations. Now, I cordially invite the chairpersons, Dr. Nisha Keshari-Bhatta and Dr. Samudra Nakandala, to present the tokens of appreciation to the speakers. Dr. Ganganath Gunatilaka, Dr. Channa De Silva, Dr. Aruna Herath, And joining us online from the United Kingdom was Professor Gary Connaught. Next up, let me invite Consultant Thoracic Surgeon Dr. Sumana Handagala to present the tokens of appreciation to the chairpersons. Thank you very much. Ladies and gentlemen, lunch will now be served and the sessions will recommence at 1:45 p.m.